Okay, Chapter 25, Care of Patients with Infection. Donna D. Ignatavicius. Uh, Learning Outcomes. For clinical competence and success on the NCLEX examination, study this chapter with these learning outcomes in mind. Safe and effective care environment. 1. Explain the Centers for Disease Control and Prevention, CDC, hand hygiene recommendations for healthcare workers. Control the transmission of infection through hand hygiene and transmission-based precautions. Apply current principles of infection control. Health promotion and maintenance. Teach patients, families, and staff about infection control measures. Teach patients and families about antimicrobial therapy. Psychosocial integrity. Assess patient-family response to transmission-based precautions. Physiological integrity. Identify patients most at risk for infection, including older adults. Provide information to patient and family about drug therapy for infections. Identify common clinical manifestations of infectious disease. Interpret laboratory test findings related to infections and infectious disease. Evaluate nursing interventions for management of the patient with an infection. Explain why multi-drug resistant organisms and other emerging infections are increasing. The human body has many protective systems that promote homeostasis. Physiologic mechanisms are the structural and functional defenses that protect people from stressors such as infection. When these mechanisms fail to work properly or are overcome with microbes, infection can result. Infections and infectious disease have been the major cause of millions of deaths worldwide for centuries. Today, threats of bioterrorism have been added to the concerns about multi-drug resistance and emerging infections. Global travel and migration have increased exposure to a wider variety of infectious agents than in the past. For example, severe acute respiratory syndrome, or SARS, monkeypox, and avian influenza, or bird flu, have appeared for the first time in the United States during the past decade. However, humans have not gotten any of these diseases yet. Advancing technology and invasive procedures also introduce microorganisms into the body, often resulting in infection, even though in other environments these microorganisms are harmless. This chapter provides an overview of infection and general principles for prevention and management. Specific infections are described elsewhere in this text. Overview of the infectious process. A pathogen is any microorganism, also called an agent, capable of producing disease. Infections can be communicable, transmitted from person to person, e.g. influenza, or not communicable, e.g. peritonitis. Microorganisms with differing levels of pathogenicity, ability to cause disease, surround everyone. Virulence is a term for pathogenicity. However, virulence is related more to the frequency with which a pathogen causes disease, degree of communicability, and its ability to invade and damage a host. It can also indicate the severity of the disease. Many microorganisms live in or on the human host without causing disease. Some microbes are beneficial. Each body location harbors its own characteristic bacteria or normal flora. Normal flora often function to compete with and prevent infection from unfamiliar agents attempting to invade a body site. In some instances, microorganisms that are often pathogenic may be present in the tissues of the host and yet not cause symptomatic disease because of normal flora. This process is called colonization. In the United States, the Centers for Disease Control and Prevention collects information about the occurrence and nature of infections and infectious diseases. It then recommends guidelines to healthcare agencies for infection control and prevention. Certain diseases, such as tuberculosis, must be reported to health departments and the CDC. The Infection Control Practitioner, or ICP, for each health care agency is responsible for tracking infections or surveillance and ensuring compliance with federal and local requirements. Transmission of infectious agents. Transmission of infection in healthcare requires three factors: reservoir or source of infectious agents, susceptible host with a portal of entry, mode of transmission. Reservoirs or sources of infectious agents are numerous. Animate reservoirs include people, animals, and insects. Inanimate reservoirs include soil, water, and other environmental sources and medical equipment, e.g. IV solutions, urine collection devices. The host's body can be a reservoir Pathogens colonize skin and body substances, e.g. feces, sputum, saliva, wound drainage. A person with an active infection or an asymptomatic carrier, one who harbors an infectious agent without the active disease, is a reservoir. Examples of community reservoirs include sewage, stagnant or contaminated water, and improperly handled foods. Bacteria like Neisseria meningitidis can exist in the respiratory tract while causing no illness. If the bacteria invade the bloodstream or cerebrospinal fluid, they become extremely pathogenic. Another example is Enterococcus, which lives as normal flora in the GI system, where it is non-pathogenic and assists in the digestive process. If it enters the bloodstream, Enterococcus can cause disease. Continued multiplication of a pathogen is sometimes accompanied by toxin production. Toxins are protein molecules released by bacteria to affect host cells at a distant site. Exotoxins are produced and released by certain bacteria into the surrounding environment. Botulism, tetanus, diphtheria, and Escherichia coli or E. coli related systemic diseases are attributed to exotoxins. Endotoxins are produced in the cell walls of certain bacteria and released only with cell lysis. For example, typhoid and meningococcal diseases are caused by endotoxins. Table 25.1 Host factors that influence the development of infection. So, host factor. Natural immunity. The increased risk of infection would be congenital or acquired immune deficiencies. Normal flora. Increased risk of infection would be alteration of normal flora by antibiotic therapy. Host factor. Age. Increased risk would be infants and older adults. Hormonal factors would be diabetes, mellitus, corticosteroid therapy, and adrenal insufficiency. Phagocytosis would be defective phagocytic function, circulatory disturbances, and neutropenia. Skin and mucus would be break in skin or mucous membrane integrity, interference with flow of urine, tears, or saliva, interference with cough reflex or ciliary actions. So that would be skin, mucous membranes, normal excretory excretions also. And it would also include changes in gastric secretions. Nutrition would be malnutrition or dehydration. Environmental factors would be tobacco and alcohol consumption and inhalation of toxic chemicals, and medical interventions would be invasive therapy, chemotherapy, radiation therapy, and steroid therapy, and surgery. Host factors influence and development of infection. Table 25.1. Host defenses provide the body with an efficient system of protection against pathogens. Breakdown of these defense mechanisms may increase the susceptibility or risk of the host to infection. The patient's immune status plays a large role in determining risk for infection. Congenital abnormalities as well as acquired health problems, e.g. renal failure, steroid dependence, cancer, acquired immune deficiency syndrome, or AIDS, can result in numerous immunological deficiencies. Depression of the immune system may make the host more susceptible to infection or cripple the ability to combat organisms that have gained entry. Immunity is resistance to infection. It is usually associated with the presence of antibodies or cells that act on specific microorganisms. Passive immunity is of short duration, days or months, and either natural by transplants, placental transfer from the mother, or artificial by injection of antibodies, e.g. immune globulin. Active immunity lasts for years and is natural by infection or artificial by stimulation of the body's immune defenses, e.g. vaccination. Chapter 19 discusses the immune system and immunity in detail. Environmental factors can also influence patients' immune status and thus their susceptibility to or ability to fight infection. Examples include alcohol consumption, nicotine use, inhalation of bone marrow, suppressing toxic chemicals, and certain vitamin deficiencies. Malnutrition, especially protein-calorie malnutrition, places patients at increased risk for infection. Diseases such as diabetes mellitus also predispose a patient to infection. Older adults have decreased immune systems as well as other physiological changes that make them very susceptible to infection. Medical and surgical interventions may impair normal immune response. Steroid therapy, chemotherapy, and anti-rejection drugs increase the risk of infection. Medical devices, e.g. intravascular or urinary catheters, endotracheal tubes, synthetic implants, may also interfere with normal host defense mechanisms. Surgery, trauma, radiation therapy, and burns result in non-intact skin. The body's skin is one of the best barriers of defenses against infection. When this barrier is broken, infection often results. Microorganisms may enter the body in a variety of ways, including the respiratory tract, GI tract, genitourinary tract, skin and mucous membranes, and bloodstream. Pathogens may enter the body through the respiratory tract. Microbes and droplets are sprayed into the air when people with infected oral or nasal tissues talk, cough, or sneeze. A susceptible host then inhales droplets, and pathogens localize in the lungs or are distributed via the lymphatic system or bloodstream to other areas of the body. Microorganisms that enter the body by the respiratory tract and produce distant infection include influenza virus, Mycobacterium tuberculosis, and Streptococcus pneumoniae. Chart 25.1, Nursing Focus on the Older Adult. Factors that may increase risk of infection in the older patient. Factor, immune system, would be decreased, aging-associated changes would be decreased antibody production, lymphocytes, and fever response. Integumentary system would be thinning skin, decreased subcutaneous tissue, decreased vascularity, and slower wound healing. Respiratory system would be decreased cough and gag reflexes. Gastrointestinal system would be decreased gastric acid and intestinal motility. Chronic illness would be diabetes mellitus, chronic obstructive pulmonary disease, and neurologic impairments. Functional cognitive impairments would be immobility, incontinence, and dementia. Invasive devices would be urinary catheters, feeding tubes, IV devices, and tracheostomy tubes. Institutionalization would be increased person-to-person contact and transmission. Other pathogens enter the body through the GI tract. Some stay there and produce diseases, e.g. Shigella, causing self-limited disease. Okay. Others invade the GI tract to produce local and distant infections, e.g. Salmonella and Enteritis. Some produce limited GI symptoms, causing systemic infection, e.g. Salmonella typhi, or profound involvement of other organs, e.g. hepatitis A virus. Millions of foodborne illnesses cases occur each year in the United States. This type of illness results in many hospitalizations and deaths. Microorganisms also enter through the genitourinary tract. UTI is one of the most common healthcare-associated infections, also called HAI, healthcare-associated infections. More than half of patients in adult intensive care units have urinary catheters in place. Indwelling urinary catheters are a primary cause of UTIs. The use of invasive catheters has decreased in long-term care settings because older adults are very susceptible to infections. Although intact skin is the best barrier to prevent most infections, some pathogens such as Treponema pallidum can enter the body through intact skin or mucous membranes. Most enter through breaks in these normally effective surface barriers. Sometimes a medical procedure creates a break in cutaneous or mucocutaneous barriers, as in catheter-acquired bacteremia, or bacteria in the bloodstream, and surgical site infections, SSIs. Fragile skin of older patients and of those receiving prolonged steroid therapy increases infection risk. Microorganisms can gain direct access to the bloodstream, especially when invasive devices or tubes are used. The incidence of bloodstream infections, BSIs, continues to increase in hospitals throughout the United States. Central venous catheters, or CVCs, are a primary cause of these infections. See Chapter 15 for more discussion of CVC-related BSIs. In the community setting, biting insects can inject organisms into the bloodstream, causing infection, e.g. Lyme disease, West Nile virus, and encephalitis. For infection to be transmitted from an infected source to a susceptible host, a transport mechanism is required. Microorganisms are transmitted by several routes: contact transmission, indirect or direct, droplet transmission, airborne transmission. Contact transmission is the usual mode of transmission of most infections. Many infections are spread by direct or indirect contact. With direct contact, the source and host have physical contact. Microorganisms are transferred directly from skin to skin or from mucous membrane to mucous membrane, often called person-to-person transmission. Direct contact is best illustrated by the spread of the common cold. Indirect contact transmission involves the transfer of microorganisms from a source to a host by passive transfer from a contaminated object. Contaminated articles or hands may be sources of infection. For example, patient care devices like glucometers and electronic thermometers may transmit pathogens if they are contaminated with blood or body fluids. Uniforms, laboratory coats, and isolation gowns used as part of personal protective equipment may be contaminated as well. Indirect transmission may involve contact with infected secretions or droplets. Droplets are produced when a person talks or sneezes. The droplets travel short distances. Susceptible hosts may acquire infection by contact with droplets deposited on the nasal, oral, or conjunctival membranes. Therefore, the CDC recommends that staff stay at least 3 feet or 1 meter away from a patient with droplet infection. An example of droplet spread infection is influenza. Unlike airborne droplet nuclei, discussed later, droplets do not stay suspended in the air. Airborne transmission occurs when small airborne particles containing pathogens leave the infected source and enter a susceptible host. These pathogens can be suspended in the air for a prolonged time. The particles carrying pathogens are usually contained in droplet nuclei or dust. They are usually propelled from the respiratory tract by coughing or sneezing. A susceptible person then inhales the particles directly into the respiratory tract. For example, tuberculosis is spread via airborne transmission. Preventing the spread of microbes that are transmitted by the airborne route requires use of special air handling and ventilation systems in an airborne infection isolation room, or AIIR. Mycobacterium tuberculosis and the varicella zoster virus, or chickenpox, are examples of airborne agents that require one of these systems. In addition to the AIIR respiratory protection, using certified N95 or higher level respiratory masks is recommended for healthcare personnel entering the patient's room. The N95 rating means that at least 95% of the inhaled air is filtered. Other sources of infectious agents include the environment, such as contaminated food, water, or vectors. Vectors are insects that carry pathogens between 2 or more hosts, such as the deer tick that causes Lyme disease. The portal of exit completes the chain of infection. Exit of the microbe from the host often occurs through the portal of entry. An organism such as M. tuberculosis enters the respiratory tract and then exits the same tract as the infected host coughs. Some organisms can exit from the infected host by several routes. For example, varicella zoster virus can spread through direct contact with infected fluid in vesicles and by airborne transmission. Physiologic defenses for infection. Strong and intact host defenses can prevent microbes from entering the body or can destroy a pathogen that has entered. Impaired host defenses may be unable to defend against microbial invasion, allowing entry of organisms that can destroy cells and cause infection. Common defense mechanisms include body tissue, phagocytosis, inflammation, immune systems. Intact skin forms the first and most important physical barrier to the entry of the microorganism. In addition to providing a mechanical barrier, the skin's lightly acidic pH resulting from breakdown of lipids into fatty acids, together with normal skin flora, creates an unfriendly environment for many bacteria. Mucous membranes, mucociliary action provides some mechanical protection against pathogenic invasion. More important, however, mucous membranes are bathed in secretions that inactivate many organisms. Lysozymes, which dissolve the cell walls of some bacteria, are present in large quantities in many body secretions, particularly in tears and nasal mucus. Other body systems provide natural barriers to infection. For instance, the healthy respiratory tract clears about 90% of all inhaled material by upper airway filtration, humidification, mucociliary transport, and coughing. Peristaltic action mechanically empties the GI tract of pathogenic organisms. Stomach acid, intestinal secretions, pancreatic enzymes, and bile, together with the competition with normal bowel flora, provide an environment that protects the GI tract from invasion by harmful organisms. In the genitourinary tract, the flushing action of urine eliminates pathogenic organisms. The low pH of urine also maintains a sterile environment, although some microorganisms, such as Escherichia coli, thrive in the acid medium. Phagocytosis occurs when a foreign substance evades the first-line mechanical barriers and enters the body. Various leukocyte types function differently in the immune reaction, but neutrophils bear primary responsibility for phagocytosis. This process of engulfing, ingesting, killing, and disposing of an invading organism is an essential mechanism in host defense. Phagocytic dysfunction dramatically increases a patient's risk for infection. Inflammation is another important nonspecific defense mechanism for preventing the spread of infection. It occurs when tissue becomes damaged. Damaged cells release enzymes, and polymorphonuclear or PMN leukocytes or neutrophils are attached to the infected site from the bloodstream. One important substance, histamine, increases the permeability of the capillaries in inflamed tissues, thus allowing fluid, proteins, and white blood cells to enter an inflamed area. Other enzymes activate fibrinogen, which causes leaked fluid to clot and prevents its flow away from the damaged site into unaffected tissue, essentially walling off the inflamed tissue. The process of phagocytosis disposes of the invading microorganism and often dead tissue. If inflammation is caused by infection, the end products of inflammation form pus, which is then absorbed or exits the body through a break in the skin. Chapter 19 discusses the process of inflammation in more detail. Specific defense responses to specific microorganisms are provided by the antibody and cell-mediated immune system. The antibody-mediated immune system produces antibodies directed against certain pathogens. These antibodies inactivate or destroy invading microorganisms, as well as protect against future infection from that microorganism. Resistance to other microorganisms is mediated by the action of specifically sensitized T lymphocytes and is called cell-mediated immunity. The components of the immune system work both independently and together to protect against infection. Chapter 19 describes the function of the immune system in detail. Health promotion and maintenance, infection control, and inpatient healthcare agencies. Infections occur most often in high-risk patients such as older adults and those who have inadequate immune systems, immunocompromised. Implement interventions to prevent infection and detect signs and symptoms as early as possible. Chart 25.2 summarizes nursing interventions for infection protection. Infection acquired is the inpatient healthcare in the inpatient healthcare setting, not present or incubating at admission, is termed a hospital-acquired infection, or HAI. HAIs can be endogenous from a patient's flora or exogenous from outside the patient, often from the hands of a healthcare worker. Therefore, use of the less popular term nosocomial infection does not imply that an infection was caused by healthcare or poor healthcare delivery, but only that it occurred while receiving healthcare. HAIs occur in about 2 million inpatients yearly, causing many deaths. Patients who develop surgical site infections, SSI, have longer and more costly hospital stays and are much more likely to spend time in an ICU. Chart 25.2 Intervention activities. The patient at risk for infection. Infection protection, prevention, and early detection of infection in a patient at risk. Monitor for systemic and localized signs and symptoms of infection. Monitor vulnerability to infection. Monitor absolute granulocyte count, WBC count, and differential results. Screen all visitors for communicable disease. Inspect skin and mucous membranes for redness, extreme warmth, or drainage. Obtain cultures as needed. Promote sufficient nutritional intake. Encourage fluid intake as appropriate. Teach the patient and family about signs and symptoms of infections and when to report them to the healthcare provider. Teach patient and family members how to avoid infections. WBC, Infection control within a healthcare facility is designed to reduce the risk of HAIs and thus reduce morbidity and mortality as recommended in the Joint Commission's National Patient Safety Goals. This goal is consistent with the desire for healthcare facilities to create a culture of safety within their environments. See Chapter 1. Infection control and prevention programs include facility and department specific infection control policies and procedures, surveillance and analysis, patient and staff education, community and interdisciplinary collaboration, product evaluation with an emphasis on quality and cost savings. The infection control program of a hospital is coordinated and implemented by a healthcare professional certified in infection control, a CIC, who has clinical and administrative experience. The previous recommendation of one CIC for every 250 occupied acute care beds has been found to be inadequate. Instead, the CDC now recommends one for every 100 occupied acute care beds. Long-term care facilities may not have a practitioner who is dedicated to infection control. However, every facility must designate someone to have the responsibility for coordinating and implementing an infection control program. Long-term care facilities are unique in that they have a large group of older adults who are together in one setting for weeks to years. Nursing homes, in particular, are required to provide a home-like environment in which residents can move and interact freely. Therefore, infection control in these settings can be challenging. As a result, many infectious outbreaks have occurred, such as pneumonia, Clostridium difficile, and multi-drug-resistant organisms. Discussed in the multi-drug-resistant organism infections and colonization section. Infection control in community-based settings. Ambulatory care is the fastest-growing segment of the healthcare system. Less information is available about acquired infection in these settings than in inpatient settings. HAIs in hemodialysis centers and emergency departments are the most common. Infections tend to occur because healthcare workers do not follow basic infection control principles, especially aseptic technique and injection practices. Methods of infection control. All healthcare workers who come in contact with patients or care areas are involved in some aspect of the infection control program of the agency. Infections can be prevented or controlled in at least 5 major ways. Hand hygiene, personal protective equipment, PPEs, also called barriers, adequate staffing, disinfection, sterilization, patient placement, and transport. Healthcare workers' hands are the primary way in which infection is transmitted from patient to patient or staff to patient. Hand hygiene refers to both hand washing and alcohol-based rubs, ABHRs. In 2002, the CDC released a document entitled CDC Hand Hygiene Recommendations. These recommendations are summarized in Chart 25.3. Hand washing is still an important part of hand hygiene, or hand washing is still an important part of hand hygiene, but it is recognized that in some healthcare settings, sinks may not be readily available. Despite years of education, healthcare workers often find it difficult to leave the patient care setting to wash their hands and do not perform hand hygiene on a consistent basis. Effective hand washing includes wetting, soaping, lathering, applying friction under running water for at least 15 seconds, rinsing, and adequate drying. Friction is essential to remove skin oils and to disperse transient bacteria and soil from hand surfaces. Performing adequate hand washing takes time that healthcare workers may not feel they have. Hand washing can also cause dry skin, and therefore hand moisturizers are essential to maintain good hand health and hygiene. Alcohol-based hand rubs have allowed care providers to spend less time seeking out sinks and more time delivering care. However, these hand rubs have the limitations. If your hands are visibly dirty or soiled or feel sticky, or if you have just toileted, wash your hands instead of using alcohol-based rubs. ABHRs are ineffective against spore-forming organisms such as Clostridium difficile, a common cause of health care-associated diarrhea, especially in older adults taking antibiotics. Do not use an ABHR before inserting eye drops, ointments, or contact lenses. Alcohol can irritate the patient's eyes, causing burning and redness. The Joint Commission requires that healthcare agencies monitor hand washing practices and the use of ABHRs to make sure that the healthcare workers are performing hand hygiene on a regular basis. The CDC recommends using antiseptic solutions such as chlorhexidine, povidone, iodine, or PCMX, or parachloromethaxylenol, for hand washing and caring for patients who are at high risk, e.g. those who are immunocompromised. The use of these solutions is also recommended after caring for patients who are infected with multi-drug resistant or other virulent organisms. The CDC guideline also addresses the issue of artificial fingernails. which have been linked to a number of outbreaks due to poor fingernail health and hygiene. The guidelines recommend that artificial fingernails and extenders not be worn while caring for patients at high risk for infections, such as those in ICUs or operating suites. Most healthcare agencies have banned artificial nails, and all healthcare workers providing direct patient care and require that natural nails be short and without nail polish. Chart 25.3. Best practice for patient safety and quality care. Hand hygiene. When hands are visibly soiled or contaminated with proteinaceous material, or are visibly soiled with blood or other bodily fluids, wash hands with soap and water. If hands are not visibly soiled, use an alcohol-based hand rub for decontaminating hands, or wash hands with soap and water. Use either alcohol-based hand rub or wash with soap and water. Decontaminate hands before having direct contact with patients. Decontaminate hands before donning sterile gloves to perform a procedure such as inserting an invasive device, e.g. indwelling urinary catheter. Decontaminate hands after contact with a patient's intact skin, e.g. taking a pulse, or with body fluids or excretions/secretions. Decontaminate hands after removing gloves. Decontaminate hands after contact with inanimate objects, including medical equipment, in the immediate vicinity of the patient. Personal protective equipment, or PPEs, refer to the use of gloves, isolation gowns, face protection masks, goggles, face shields, and respirators with N95 or higher filtration. Gloves are an essential part of infection control and should always be worn as part of standard precautions. Either hand washing or use of alcohol-based hand rubs should be done after removing gloves. The combination of hand hygiene and wearing gloves is the most effective strategy for preventing infection transmission! Exclamation point. Most healthcare settings in the United States and Canada have switched from latex to non-latex gloves. The U.S. National Institute of Occupational Safety and Health, or NIOSH, issued a public warning about potential allergic reactions to those exposed to latex in gloves and other medical products. Reactions include rashes, nasal or eye symptoms, asthma, and rarely shock. People with latex allergy usually have an allergy to foods such as bananas, kiwis, and avocados. Hands should be washed after removal of latex gloves to minimize contact time between the skin and proteins in the glove that may cause allergic reactions. Healthcare workers have not been as strict with wearing gloves as they should because of poor fit or skin dryness, irritation, and dermatitis. One possible solution to dry skin is the use of aloe vera coated gloves. In a study of healthcare workers in 3 U.S. and 1 Canadian hospital, the subjects preferred the aloe vera gloves over gloves without the moisturizers. Oh yeah. In addition, they were more compliant with wearing the study gloves because they had less dryness and skin irritation. Adequate staffing of healthcare workers is an essential method for preventing infection. In addition to a ratio of 1 infection control practitioner to 100 occupied acute care beds, nursing staffing is critical. The CDC recommends that 2 methods to ensure adequate infection control be implemented. First, an infection control nurse liaison should be designated on every unit of an inpatient facility. This nurse is responsible for implementing new IC policy, or infection control policy. Increasing staff IC compliance through education and collaborating with the facility's ICP to monitor for infections. Second, bedside nurse staff should consist of full-time nurses assigned regularly to the unit rather than float, pool, or agency nurses. Studies have found that infection rates increase when float, pool, or agency nurses are substituted for full-time regular staff. Boo. Sterilization and disinfection have helped invasive procedures become much more common and safe. Sterilization means destroying all living organisms and bacterial spores. All items that invade human tissue where bacteria are not commonly found should be sterilized. Disinfection does not kill spores and only ensures a reduction in the level of disease-causing organisms. High-level disinfection is adequate when an item is going inside the body where the patient has resistant bacteria or normal flora, e.g. GI and respiratory tracts. As with sterilization, no high-level disinfection can occur without first cleaning the item. This can be especially difficult with items that have narrow lumens in which organic debris can become trapped and is not easily visible. For example, endoscopes have been especially challenging to clean and have been linked to a number of infectious outbreaks. Environmental cleaning procedures for patients' rooms were also outlined by the CDC in 2007. Patient placement has been used as a way to reduce the spread of infections. Some studies have suggested that private patient rooms help decrease infections. However, the CDC has not mandated that all patients, even those with infections, have a private room. The CDC does recommend that private rooms always be used for patients on airborne precautions and those in a protective environment, or PE. A PE is architecturally designed and structured to prevent infection from occurring in patients who are at extremely high risk, such as those having stem cell therapy. The CDC also prefers private rooms for patients who are on contact and droplet precautions. Many hospitals are increasing their number of private rooms, and some are becoming totally private room facilities. Cohorting is another method of patient placement. Cohorting is the practice of grouping patients who are colonized or infected with the same pathogen. This method has been used used the most with patients who have an outbreak of multi-drug resistant organisms like methicillin resistant, MRSA. It is particularly effective in long-term care settings. Okay. Transmission-based infection control precautions. Precaution. In addition to standard precaution. Airborne precautions. Private room required with monitored negative airflow with appropriate number of air exchanges and air discharge to outside or through HEPA filter. Keep door closed. Examples of diseases in category would be diseases that are known or suspected to be transmitted by air, like measles. Special respiratory protection. N95 respirator for known or suspected TB. Susceptible persons not to enter room for patient with known or suspected measles or varicella unless immune caregivers are not available. Susceptible persons who must enter room must wear N95 HEPA filter. So that would be for measles, tuberculosis, MRSA, varicella, shingles. Transport patient to leave room only for essential clinical reasons, wearing surgical mask. Okay, that's also for all that. So droplet precautions. Excuse me. Private room preferred if not available. Make cohort with patient with same active infection with same microorganisms. If no other infection present, maintain distance of at least 3 feet from other patients if private room not available. Mask required when working within 3 feet of patient, and transport as above. Diseases that are known or suspected to be transmitted by droplets would be diphtheria, pharyngeal, streptococcal, pharyngitis, pneumonia, influenza, rubella, invasive disease, meningitis, pneumonia, sepsis caused by Haemophilus influenza type B or Neisseria meningitis, mumps, and pertussis. Contact precautions would be a private room preferred. If not available, may cohort with patient with same active infection with same microorganisms if no other infection present. Wear gloves when entering room. Wash hands with antimicrobial soap before leaving patient's room. Wear a gown to prevent contact with patient or contaminated items, or if patient has uncontrolled body fluids, remove gown before leaving room. Transport patient to leave room only for essential clinical reasons. During transport, use needed precautions to prevent disease transmission. Dedicated equipment for this patient only, or disinfect after use before taking from room. And diseases with contact precautions would be Clostridium difficile or C. diff, colonization or infection caused by multi-drug resistant organisms, MRSA, VRE, pediculosis, respiratory syncytial virus, respiratory syncytial virus, scabies, viral hemorrhagic infections, e.g. Ebola. Ugh. Okay, standard precautions. Oh. I'm about done with this. This is so old. I'm not reading any more of this. Sorry. I'm not going to read another hour of this crap. Excuse me. Alright, I'm going to skip all that because it's just so old. And they've pretty much given us all that information. So let's go 481 to 484, the skin problems. So first is sunburn. Sunburn is a first degree or superficial burn and a very common skin injury. Excessive exposure to ultraviolet or UV light injures the dermis, stimulating an inflammatory response that dilates the capillaries, leading to redness, tenderness, edema, and occasional blister formation. When large areas of the body are sunburned, systemic inflammatory systems such as headache, nausea, and fever may be produced. Erythema, or redness, and pain begin within a few hours after sunburn has occurred and increase in intensity for 1 to 2 days before subsiding. Treatment is directed toward comfort and includes cool baths and soothing lotions, such as bland lubricants or refrigerated moisturizing lotions. Antibiotic ointments are used only if blistering of the skin causes infection. If pain is severe, topical corticosteroids may decrease the inflammation temporarily. See Chapter 28 for discussion of prevention and treatment of superficial burns. Urticaria. Urticaria, or hives, is white or red edematous papules or plaques of various sizes. This problem is usually caused by exposure to allergens for different people, which releases histamine in the dermal tissue, causing blood vessel dilation and leakage of plasma protein to form lesions or wheals, spelled W-H-E-A-L-S. The exact cause is rarely identified, although drugs, foods, infections, autoimmune diseases, cancer, and physical stimuli often trigger urticaria. Treatment for urticaria is aimed at removal of the triggering substance and relief of symptoms. Because the skin reaction is caused by histamine release, antihistamines such as diphenhydramine or Benadryl are helpful. Teach the patient to avoid overexertion, alcohol consumption, and warm environments, e.g. warm or hot showers, which contribute to blood vessel dilation and make the symptoms worse. In addition, alcohol may increase any sedating effect of antihistamines, increasing the risk for falls and other accidents. Trauma. Pathophysiology. Skin trauma can vary from an aseptic surgical incision to a grossly infected, draining pressure ulcer with a deep tissue destruction. Injury to the skin starts a series of actions to repair the skin and reestablish this protective barrier. Table 27.1, normal wound healing. Inflammatory phase. Inflammatory phase begins at the time of injury or cell death and lasts 3 to 5 days. Immediate responses are vasoconstriction and clot formation. After 10 minutes, vasodilation with increased capillary permeability and leakage of plasma and plasma proteins into the surrounding tissue. Migration of white blood cells, especially macrophages, into the wound. Then clinical manifestations of local edema, pain, erythema, and warmth. Fibroblastic phase. This begins about the 4th day after the injury and lasts 2 to 4 weeks. Fibrin strands form a scaffold or framework. Mitotic fibroblast cells migrate into the wound, attach to the framework, divide and stimulate the secretion of collagen. Collagen, together with ground substance, builds tough and inflexible scar tissue. Capillaries in areas surrounding the wound form buds that grow into new blood vessels. Capillary buds and collagen deposits form the granulation tissue in the wound, and the wound contracts. Epithelial cells grow over the granulation tissue bed. Then the maturation phase begins as early as 3 weeks after injury and may continue for a year. Collagen is reorganized to provide greater tensile strength. Scar tissue gradually becomes thinner and paler in color. The mature scar is firm and inelastic when palpated. Phases of wound healing. Wound healing occurs in 3 phases: the inflammatory or lag phase, the fibroblastic or connective tissue repair phase, and the maturation or remodeling phase. Table 27.1 lists the key events of normal wound healing. The length of each phase depends on the type of injury, patient health, and whether the wound is healing by first, second, or third intention. The wound without tissue loss, such as a clean laceration or a surgical incision, can be closed with sutures or staples. The wound edges are brought together with the skin layers lined up in the correct anatomic position, or approximated, and held in place until healing is complete. Because the wound can be easily closed and dead space eliminated, healing by first intention shortens the phase of tissue repair. Inflammation resolves quickly, and connective tissue repair is minimal, resulting in a thin scar. Deep tissue injuries are wounds with tissue loss, such as a chronic pressure ulcer or venous stasis ulcer, result in a cavity-like defect that requires gradual filling in of the dead space with connective tissue. This healing occurs by second intention and prolongs the repair process. Wounds with a high risk of infection, such as surgical incisions that enter a non-sterile body cavity or traumatic wounds that occur under unclean conditions, may be intentionally left open for several days. After debris, dead cells and tissue, and exudate have been removed, debrided, and inflammation has subsided, the wound is closed by first intention. This type of healing involves delayed primary closure or third intention and results in a scar similar to that form found in wounds that heal by first intention, as shown in Table 27.2. Healing can be impaired by many factors. Mechanisms of wound healing. When injury occurs, the body restores skin integrity through 3 processes: re-epithelialization, granulation, and wound contraction. The depth of injury and extent of tissue loss determine how and to what degree each of these processes contributes to wound healing. Partial thickness wounds. Partial thickness wounds are more superficial, involving damage to the epidermis and upper layers of the dermis. These wound heal by re-epithelialization, the production of new skin cells by undamaged epidermal cells and the basal layer of the dermis and the linings around hair follicles and sweat glands. Skin injury is followed immediately by local inflammation. The inflammatory response causes the formation of a fibrin clot and the release of growth factors that stimulate epidermal cell division or mitosis. New skin cells move into open spaces on the wound surface where the fibrin clot acts as a frame or scaffold to guide cell movement. Regrowth across the open area or resurfacing is only one cell layer thick at first. As healing continues, the cell layer thickness and stratifies. The cell layer thickens and stratifies, forms layers to resemble normal skin. A healed wound reestablishes the protective barrier properties of the skin with keratin production. Table 27.2 Causes of impaired wound healing. Altered inflammatory response. Local. Arteriosclerosis, diabetes, vasculitis, thrombosis, venous insufficiency, lymphedema, pharmacologic vasoconstriction, irradiated tissue, crush injuries, primary closure under tension. And then the mechanism would be reduced local tissue circulation, resulting in ischemia, impaired leukocyte response to wounding, and increased probability of wound infection. And that was Altered inflammatory response, local. Altered inflammatory response, systemic, would be leukemia, prolonged administration of high-dose anti-inflammatory drugs such as corticosteroids or aspirin. Mechanism would be systemic inhibition of leukocytic response, resulting in impaired host resistance to infection. And then there's the impaired cellular proliferation, local, would be wound infection, foreign body, necrotic tissue, repeated injury or irritation, movement of wound, e.g. across a joint, and wound desiccation or maceration. Mechanism here is prolonged inflammation response, which can result in low tissue oxygen tension and further tissue destruction. And then a systemic impaired cellular proliferation would be aging, chronic stress, nutritional deficiencies, calories, protein, vitamins, minerals, water deficiencies, impaired oxygen, pulmonary insufficiency, heart failure, hypovolemia, and then cirrhosis, uremia, prolonged hypothermia, coagulation disorders, and cytotoxic drugs. And the mechanism here would be impaired cellular proliferation and collagen synthesis, decreased wound contraction. Back to text. In a healthy patient, healing of a partial thickness wound or reepithelialization takes about 5 to 7 days. This process occurs most rapidly in tissue that is hydrated and oxygenated and has few organisms present. Full thickness wounds. In deep partial thickness and full thickness wounds, damage extends into the lower layers of the dermis and underlying subcutaneous tissue. As a result, most, if not all, of the epithelial cells at the base of the wound have been destroyed. Thus, reepithelialization is not the major healing process for this type of wound. Removal of the damaged tissue results in a defect that must be filled with scar tissue or granulation for healing to occur. During the proliferative phase of healing, new blood vessels form at the base of the wound, and fibroblastic cells begin moving into the wound space. Fibroblasts deposit new collagen to replace the damaged tissue. Some of these fibroblasts take on the features of smooth muscle cells and begin to pull the wound edges inward toward along the path of least resistance or contraction. See Figure 27.1. This causes the wound to decrease in size at a uniform rate of about 0.6 to 0.75 millimeters a day. Complete closure of a wound by contraction depends on the mobility of the surrounding skin as tension is applied to it. If tension in the surrounding skin exceeds the counterforce of wound contraction, healing will be delayed until undamaged epidermal cells at the wound edges can bridge the defect. Unlike reepithelialization in partial thickness wounds, which result in the return of near normal epithelial barrier, the bridging of epithelial cells across a large area of granulation tissue results in an unstable barrier. A venous leg ulcer is one example of a skin defect that heals poorly by contraction. Reepithelialization of these chronic wounds often result in a thin epidermal barrier that is easily re-injured. Reepithelialization, granulation, and contraction do not continue indefinitely. Natural healing processes can slow down and even stop in the presence of infection, unrelieved pressure, or mechanical obstacles. For example, dead tissue not only supports the overgrowth of organisms, but also obstructs collagen deposition and wound contraction. Therefore, thorough wound debridement is necessary for healing to occur. In the case of chronic wounds, healing may cease spontaneously and without an obvious cause. In addition, infection in chronic wounds may not show the expected manifestations. Often the only manifestation is failure of the wound to decrease in size or to actually increase in size. Considerations for older adults. As skin ages, the process of wound healing becomes less efficient. Both reepithelialization and wound contraction slow, and replacement of connective tissue is reduced. Thus, the strength of a healed wound in an older adult is reduced and the area is at greater risk for re-injury. When aging skin is further hindered from healing by inadequate nutrition, incontinence, or immobility, any wound in an older adult has a high risk for becoming a chronic wound. Although prevention strategies are best, aggressive treatment of any degree of loss of skin integrity, no matter how small, should be started as soon as it is discovered in an older adult. Patient-centered collaborative care. Treatment of skin trauma varies with the depth and type of injury. The collaborative management of any type of skin trauma focuses on enhancing wound healing, preventing infection, and restoring function to the area. Management of pressure ulcers presents interventions common to wound healing, as does treatment of burns. See Chapter 28. Pressure ulcers. Pathophysiology. Pressure ulcer is a tissue damage caused by the skin and underlying soft tissue are compressed between a bony prominence and an external surface for an extended period. Although they commonly occur over the sacrum, hips, and ankles, pressure ulcers can occur in any body surface. For example, nasal cannula tubing that is too tight can cause pressure ulcers behind the ears or in the nares. Tissue compression from pressure restricts blood flow to the skin, resulting in reduced tissue perfusion and oxygenation, leading to cell death. Ulcers occur most often in people with limited mobility because they cannot change their position to relieve pressure. Sensory impairment is also a contributing factor. Patients who cannot feel or communicate the pain that occurs with unrelieved pressure are more likely to develop pressure ulcers. Once formed, these chronic wounds are slow to heal, resulting in increased morbidity and healthcare costs. Complications associated with chronic pressure ulcers include sepsis, kidney failure, infectious arthritis, and osteomyelitis. In addition to pressure, other factors increase the risk of pressure ulcer formation. Friction and shear are mechanical forces that impair skin integrity and set the stage for skin breakdown. Excessive skin moisture, such as urinary incontinence, increases the risk for skin damage when mechanical forces are applied. Nutritional status is also a concern. Protein malnutrition not only makes normal tissue more prone to breakdown but also delays healing. All right, well, that's it for that one.